Welcome to the IRACON-TV. And we have with us Professor Laurent Arnaud. He's a professor of rheumatology in Strasbourg, France, and he's also the president of the European Lupus Society. Welcome, Professor Arnaud. Good morning.
Good morning. Thank you very much. It's my first time in India. I'm very, very happy to be here and meet my rheumatology colleagues from India. It's a great opportunity.
Yes. So it's only early days into this conference, early hours actually into this conference yet. But what was your initial impression of this IRACON and this conference setting in India?
I think that is really great. The convergence of so many rheumatologists in one same place and the opportunity to discuss, I think that is what is needed to advance science and also the care of the patients. So I think the venue is beautiful. It's very great. I'm happy to be here.
Great. So you'll be speaking on the latest updates in lupus at this meeting. So what are the top 2 updates or advancements in the field that you are the most excited about right now?
So I think you noticed there are many novelties in the context of lupus. The rooms are usually very full, so there's a great interest. If I had to pick 2, I think the first one I would say is disease modification. So it's not a new concept, but with strict to target, it's probably a way to improve the care of the patient. And my second pick would be digital rheumatology. I think it's very advanced in cancerology or cardiology, but not so much in the context of rheumatology. And I think it can be really interesting to take care of very specific aspects of lupus. And I'm thinking non-pharmacologic management.
Yeah, as I could see in a profile that you've taken to digital rheumatology over the last few years.
It's a great thing.
So is there any specific point you would like to make where you are looking at putting this digital rheumatology to use in lupus?
Absolutely. I think with the duration of a consultation, just a few minutes, 10 minutes, 15 minutes, we do not have the time to take care of lupus patients in a global manner, especially fatigue is a complex complication. And I think digital rheumatology, digital therapeutics may help us to tackle the problem of fatigue in lupus.
So recently we had this 2023 update of the EULAR recommendations for treatment of lupus. So we've all gone through that. But what are your top 2-3 takeaways from this update?
Thank you. Yeah, it was great. I'm part of this update committee, and we had great discussions at EULAR. So I can take a few messages. I think the first one is that all lupus patients should receive hydroxychloroquine. It's an easy message. Everybody's convinced. But when you look at the data from cohorts, we see that at least 20% of lupus patients are not receiving hydroxychloroquine. And I did a nationwide study in France for the year 2019. I checked which proportion of lupus patients went to a pharmacy to buy hydroxychloroquine. And the answer is 60% for the full country. So we are really far from the target. And that's, I think, the number 1 target. I think the other challenge is corticosteroids. I think it's the same everywhere. We are using too much corticosteroids with all the side effects, but it works very well. So this is why we're using corticosteroids so much. And I think we changed the maximum chronic use from 7.5 to 5 milligram of prednisone maximum if we cannot withdraw corticosteroids. And I think that's a great addition. I was not happy with the 7.5.
So many of us feel that it's quite a welcome addition to the update in the 2003. Yeah. So while being on that point, how often do you personally try and withdraw glucocorticoids in lupus? I mean complete withdrawal. Yeah. And can you see a subset of patients of lupus where it might likely to be more possible for us to completely withdraw glucocorticoids?
Thank you very much. I think it's a great question and it's a very trendy debate. As you know, there's a publication, a randomized controlled trial in ARD with the abrupt stop of 5 milligrams of corticosteroids published by Matthew. And it shows that these patients will have more flares. So it really raises this question, shall we stop or not corticosteroids in all our lupus patients? Well, I don't have a formal answer, but I try. I try to stop in all lupus patients, and sometimes it's not possible because the level of disease activity needs us to add another type of treatment. And despite that, sometimes we cannot stop corticosteroids. And I must say that in some specific subgroups, I'm always concerned about stopping completely corticosteroids. And I'm thinking patients with very severe lupus. If you had a very severe case of neuropsychiatric lupus with psychosis, is it not better to give a little bit of corticosteroids, less risky than to stop completely? I think we don't have the answer as today, but I'm sure that in the next months we will learn more about that.
So while we are on that point, another talk you're having at this IRACON is on CNS lupus.
Yes, correct.
So we'd like to know how it has evolved, the understanding of CNS lupus, the management, and with regards to the guidelines, there is something on it in the 2003 update as well. So what would you like to tell us upon that?
So thank you for your question. Thank you for your invitation to talk about CNS lupus, because I think it's a complicated manifestation. I think it was 2 years ago, I did a survey, Twitter survey on my Twitter account, and people voted CNS lupus as the #1 most difficult to treat manifestation in lupus. So tomorrow or the day after tomorrow, we're going to review the management. But I say, unfortunately, there are not so many advances. It still relies on simple thing, an MRI of the brain, a lumbar puncture to rule out an infection. But we don't have good therapeutic data. The patient with lupus involving CNS, especially when it's severe, are usually excluded from trials. And I think we need post-hoc analysis, we need specific trials, and we don't have so many data so far.
Agree. So 2 quick drug-related questions. First is related to hydroxychloroquine and the estimation of levels that we have been talking over for these last few years. So how do you see it? How readily should clinicians take to or try to get these hydroxychloroquine levels done?
It completely changed my life. I think I have a before and after, and being able to measure hydroxychloroquine blood levels, it changed everything. Because when you are confronted to a flare, then you can know whether the flare is due to the fact that the treatments are not taken, which is so common in a chronic disease such as lupus, or whether the flare is due to the fact that this is a refractory patient and you need to increase the treatment. And it's very different, because if the flare is due to the lack of therapeutic adherence, we will just start the same treatments again and discuss with the patient. And then when it's a flare and the treatments are taken, we need to add something else. So it's completely different. And I must say, I'm traveling the world quite a lot. There are only a few countries where the measurement is really available. In France, it's been 15 years. It cost around €40, $40. So it's not cheap. But in a context of a flare, I think it's better than starting a new treatment without checking.
So when we look at, say, resource-constrained settings, do you have any tips for us when we should actually not do away with doing these levels, or we should be doing these levels in certain patients? Do you have any tips for that?
Yeah, I think it's a very open debate, but I think the best timing is in case of a flare. This is really where you want to know if it's due to the fact that the treatments are not taken or not. So you can do it in several contexts, but I think that's the best context.
We're quite excited when this trials or baricitinib started in lupus. Yes. So has the final word been written on baricitinib SLE?
I don't think so. But, we have 2 trials. One is positive, the other one is negative. I'm talking phase 3 trials, and this has always been disappointed. In a way, the pharmaceutical company has decided not to go on with lupus as a formal indication, but it does not mean that it does not work, at least in some patients. So it is an off-label option in refractory patients, especially, I think, with joint involvement or skin. But the true question is also the safety. This is a new drug. You know that there is a signal for thrombosis, and lupus patients already have an increased risk of thrombosis. There's also the question of safety regarding cancers in a young population that is going to be treated for years. So I think there are more questions than answers. But this is definitely an off-label possibility when refractory patient, for instance.
Fine. So it's been quite insightful talking to you.
Thank you very much.
Thank you, Professor Arnaud, for taking our time. Thank you.